In terms of choosing first generation versus second generation TKI in order to achieve fast and deep molecular response, I have to say that in general, or at least in our practice, in my practice, we use most of the time second generation TKI with the goal to really produce already mentioned early molecular response that is very well associated with less event-free survival and overall survival in general, right? I have to say that it's true that there's not been convincing data or convincing evidence that dasatinib or nilotinib are superior overall survival in comparison with imatinib. However, we know that high or intermediate risk patients are the patients who maybe benefit the most from second generation TKI in order to decrease the rate of transformation in the first year or two. Also, I have to say that in the younger population in general, right, you may argue that younger population is everyone under 60 or even under 65, the obtention of a very early molecular response and is very well associated with complete molecular response later on, once again open the possibility to this great avenue of discontinuation that patients really wishing for their future therapies. We now these days is a part of the NCCN guidelines, and I think this is a great opportunity to introduce the second generation TKI with the goals I already mentioned, early molecular response and fast response, so we can really in the future take them out of the drug.
At this time, the data does suggest that starting with the second generation TKIs, namely nilotinib or dasatinib, or potentially bosutinib, could result in a more rapid complete molecular as well as major molecular remissions at 12 and 18 months. The question that a lot of community physicians have, or even academic physicians have, that will this translate into clinical outcome benefits for patients, such as improvement in overall survival or reductions in toxicities. A number of these studies are being followed at this time, and it does seem that the curves are showing that there is a trend to improved event-free survival in patients who get the second generation tyrosine kinase inhibitors. The overall survival data at this time do not show a significant improvement, but that may just be because these studies have now been around for only 8 or 9 years, and we have often seen that for such chronic diseases it may take 15 to 18 years. So the answer would be, in general, in leukemias as well as solid tumors, achievement of deeper remissions, whether they have been complete or major molecular, have always been associated with better survival outcomes in general. And so our suggestion would be to consider second generation tyrosine kinase inhibitors because they meet this parameter of a deeper response.
In terms of which factors I really consider when I stratify my patient, definitely age is an important one. However, age is also involved in the classical SOCAL or HASFOR criteria. Very classical criteria that we have been using for many years, SOCAL since almost the 80s, HASFOR later on. SOCAL comes from the interferon and transplant era, and definitely HASFOR after the introduction of interferon. UTOS score is also being used in Europe mainly, less used in the US. In my personal practice or in my environment, I really rely mostly on SOCAL score because it's the one who been used the better, at least it produced better results in my case.